Hello, I'm Mallie Shantzfeld, Managing Editor of Implant Practice US, a MedMark publication. Welcome to a live presentation and question and answer with oral surgeon Dr. Michael Block. In our webinar today, we will be exploring the concept and workflow to utilize intraoral scanning to aid in planning implant cases. Before we get started, I would like to invite viewers to use the question box in your control panel to ask any questions, and your questions will be answered at the end of the session. I'm pleased to introduce our guest for today, Dr. Michael Block. Dr. Block graduated from the University of Rochester in 1975, attaining both a BA in biology and a BS in biomedical engineering. He completed his dental training at the Harvard School of Dental Medicine in 1979, receiving his DMD cum laude in a special field. He completed his residency program in oral and maxillofacial surgery at the LSU School of Dentistry in 1983. He remained at the LSU School of Dentistry and achieved the academic rank of professor in the Department of Oral and Maxillofacial Surgery. Currently, he's in private practice dedicated to patient-oriented care. Dr. Block is the editor-in-chief of 5 textbooks on dental implants. He's particularly interested in the translation of technology for efficient and predictable reconstruction of the jaw to provide ideal bone for implant placement and aesthetic replacement of missing teeth, the use of multiple techniques and implants to reconstruct significant atrophic conditions, and interceptive strategies for rehabilitating extraction sites with implant restorations. Dr. Block, we turn the webinar over to you to learn more about our topic for today.
Well, thank you. I hope everyone can see the screen. Can you just confirm that for me? Everything looks good?
I can see the screen and everything looks really good.
Perfect. All right, well, let me get started then. I have a lot of material to show, and I just want to thank Carestream and the webinar group for putting this together. They're very, very professional, and this has been seamless for me, so I appreciate the professionalism. So the idea today is for me to show you how you can use digital imaging for efficient implant planning. And so one of the things that we're going to do first is talk about the problem. In my practice, I'm in private practice, and my biggest problem is to determine the final result that we want to achieve without a lot of time delays. What do I mean by that? If a patient comes in and we say we need a setup, then the patient would normally or traditionally go to the dentist. They would take impressions and they would have the lab set teeth, because most dentists don't do that. And then they would get some sort of model back, and then to translate that into your actual surgical procedure or plans is difficult. So we use digital imaging to do that, and the time delays are minimal. Then once we determine the procedures that we need to perform to get to the final result, then we let the patient know that, and then we orchestrate the plan. So basically what we're trying to do is make things more efficient, because time is really a very important thing for us. We don't have a lot of time. Patients don't have a lot of time. So that's the thrust. The other thing that we have to do is when we place an implant, we have to make sure it's accurately and precisionally placed. So what does that mean? It means it has to be accurate and precisely in the right position every time for every patient. So if we just look at what accuracy means on the left side of your screen, maybe we can see my arrow. You can see this screen on the left is low accuracy. It's not in the middle, but the precision's good. It's tight. But can you imagine all your implants being 2 millimeters off in every direction? That wouldn't work. And then the middle screen shows that in general, it's a fairly accurate collection of the implants, but the precision isn't good. So the standard deviation, so to speak, with precision is bad. The screen on the right is really what you want. You want high accuracy and high precision every time for every patient. So that's what we're going for. And we really need to make it for every patient every time. There are no easy cases. There are no simple cases. They're all unique. Every patient deserves our best. So that's the whole idea behind this. Now, when you talk about technology, if you walk into an operating room in a hospital, you don't see the traditional old style stuff that I had when I was a resident. But now you're seeing this modern era. You're seeing CAT scans that are mobile. You're seeing arthroscopy, and you're seeing imaging and all those kind of things. So it's good. Now the webcam is closed by the organizer. Can you still see everything?
I just cam, Dr. Block. No worries.
We're good?
We're good.
Okay,
Yes.
good. All right, I'll just keep going. I had a pop-up. So now if what we want to do is something like this. So what you see in front of you is, in the brown, is a three-dimensional view of a cone beam CT scan. But in the white, you see the intraoral scan of the patient, which is an STL file. And that's .stl, like .mov, .mp4, .doc. This is .stl. It's a three-dimensional image. And you can see it's been superimposed on the CAT scan. And then you can see an implant positioned right here. You can see that implant up there. So that's what we're doing. Now, what we like to do is when you place the implant, to see the navigation. So the navigation that's done is real simple. It's we're looking at the screen and we'll put the implant in. So you see the yellow is depth and the handpiece. And I'm looking at the screen when I'm putting this in. So it's a live interaction between the patient and my drill. And by doing that, I can navigate the system very accurately. And this is just like tracking software you'd see in the hospital or you'd see the Air Force does with bombs and rockets. So it's a very effective way of doing things. From the evidence-based point of view, we've done several studies and published them, and you can go to pubmed.gov and look at my name and pull this up. Well, we had one study that we did, and it had over 500, about 500 patients, 700 excess implants, and with different surgeons. And we found that when we did fully guided, in other words, when we guided the implant in with this dynamic navigation, we were about 3 degrees off of perfect. And that's reasonable. Small deviations, platform deviation about 1, apical deviation about 1. So these numbers, these 3 degrees off, 1 and 1, are pretty much what you're going to see in static guides or any other navigation. This is fully guided, and this is quite accurate. This is quite accurate. And you contrast that with the freehand, which is, in other words, you have the plan, but you didn't use the machine, and you just eyeballed it. That's by hand. You just drill the hole. And now you're 7 to 8 degrees off, and the deviation's larger. And now you see you're almost 2 millimeters off the platform. So there's definitely an improvement with navigation. It's statistically valid, across the board, multiple surgeons, and it works. So I would just challenge you who's listening to say that if dynamic and static guides, which is the ones with the metal sleeves, are both better than freehand, well, should we feel guilty if we don't use navigation? Or should you always use navigation? I think you should. I think you're going to find that it's just like the old Panorex and the cone beam. A long time ago, we had a Panorex, we were using it. Then everyone went to cone beams. And now, if you don't use a cone beam doing implants, you're sort of not following not a standard, but a very strong encouragement of using that machine. And I think navigation is going to be the same thing because you can do it better. So I think this is something you're going to have to think about because the technology actually works. It works every time. So what's our workflow? How do we pull this together? So this is a patient, and this is not a patient. This happens to be my daughter who's an orthodontist, but I needed a photo. So a patient comes in, and what we do in our office is we put them in the chair and we talk to them. We say, what can I do for you? What do you need? And then based on what they say, then we go ahead and get the scan. So there's the cone beam scans that you use, they're different. I would say that the Carestream one is really good. I have a different version because I bought it a long time ago. The scanners, the intraoral scanners, there's 3 top ones in there. And this is the one I use. I use the Carestream 3600. And I'm using that name because I can and because Carestream is also supporting this. But the Carestream scanner is great. You buy it for 1 fee and then you're done. You don't have to pay an annual fee. Upgrades are free. And it really is fast. And it works great. So I scan the patient with both scans, and then I marry the 2 images. I marry the 2, and so what you see here is a scanned model. This is a model of a patient with a workup, and then you see the green is the bone, and then I could put implants in according to all that, and I didn't have to do a whole lot of other strange things to this case. Now, when you're doing the implants, this is the way this works. You can see the blue light above, and the technology is good because now the lights shine down. And off of the handpiece and the patient tracking array, then the light bounces back up and into these high definition cameras here. And then you have the image on the screen. Now, it's always important to get someone to photograph yourself because you might be surprised what you see. Look at my neck, not very good. So now I'm moving the system. I'm moving this over to where she is almost, to that area here. So now I'm squaring my shoulders. And just by having somebody take a picture, I'm learning how to stand and work a little better for my back and my neck. And so I'm standing straight up when I'm doing this. You can sit down and do these. It's just very easy to use these systems. So our current workflow is to take an intraoral scan or scan of the models. If you have a model set up, that's great. And then take the cone beam with a patient tracking array or clip, and then put these files together and visualize the plan, and then put the implants in. All of that planning on the CT and on the computer, this is done on the actual navigation computer itself, which is, I use XNav. It's all in there. It takes me 10 minutes, literally 10 minutes. I had a half hour to wait before doing this, and I went and did it, a couple cases just to get them set up. So who would I see? This is a normal, everyday type of occurrence. Patient comes in, she's going to lose on the maxillary right side, teeth number 3 and 5. And these are fractured. They need to be removed. She's having a mitral valve replacement as well. So I removed the teeth because we didn't want to have the infected teeth when she has her valve replacement. And then you see about a year later, she comes in, and we got a little porosity going on in the bone. So we'll use appropriate drills. But now if you look at the Panorex at the bottom over here, where do I put the implants? So I can put them anywhere I want. I can put them laterally or palatally. So I really don't know where to put them. And instead of having the dentist get an impression and set it up, what I did, I scanned the patient intraorally. So it took me literally 8 minutes to scan this case, upper, lower. Notice I can get the edentulous arch up here. And then you get an occlusion. So then I export that from the scanning computer to a flash drive, put it in the navigation system, and then I upload it into there. And when I superimpose it on the scan, what you see here on the left is this is the cone beam, and in the middle you see the STL file. And then I pick like landmarks. So that's one landmark, and then I pick another one, then I pick another one. So I've got 3 landmarks that I've isolated on both images. And then what happens is that they get superimposed automatically. So you see here I've got 3 dots, and now the images are there, and I look at the image on the right screen, and I turn it around and move it around, and it looks good. I'm ready to go. So what I do at that point is I put virtual teeth in place. So you can see here how number 2 is locked in, and then number 3 would be the mesial palatal cusp on both teeth, and you identify those, and then you stitch it together. Now with the teeth in occlusion from the virtual scan, now why is that different than the normal? When you take a cone beam for this, you have the patient having the patient tracking array or clip in there. You have cotton roll, so the mouth's open a little bit, so you don't have them in occlusion. And so this shows you an image with the teeth in occlusion. And then what I do is I just take virtual crowns. I just identify teeth 3, 4, and 5, and they put them in there, and then I just move them around a little bit so they occlude the lower. I'm a dentist, I should be able to do that. And you can see on the slides here how nice the occlusion is. And then I put the implants in, and I have them emerging exactly where we want them to come out. And that whole planning process took me about 10 minutes. So this whole digital imaging thing works, and it works to save me time, saves my referrals time, it saves the patient a lot of time, because they're very busy people. They don't want to be running all over over creation to getting all this done. So this is very simple for them. And I take these images and I send them to my dentist, and I say, hey, do you like where it's placed? And they say, sure, we're good. And so then but you see the implants are placed. But mainly the teeth are in occlusion. You see that's what it is. I've got the opposing occlusion set up. So I can do this all day long. This is easy. Now, when I put the implants in, I have them lined up just like you see. And then on this particular navigation system, I don't need any of these images. I just put the implants in. And I use it because the plan's made. So here's the plan, and here's the implants in position. So they're right in the middle of the alveolus. And you can see on any of these implants, if I had a freehanded, I can put them all over the place. But they're lined up, and they work fine, and she got restored without a problem. Another patient is a woman of 61. She has recurrent decay on the maxillary left first and second molars. So I take them out, and I graft the sockets. They're large teeth, large sockets, so I graft them. And now we come back, and we have sufficient bone to put implants in. But again, where am I going to put the implants? See, when I have a large, broad ridge, I can put them anywhere. I can put them palatal. I can put them facial. So what I do is I scan the patient. So what you see here in this image is on the right screen, you see the lower teeth in occlusion with the upper. And what you can do is pick what you want to see. You can just pick the upper image. You can pick the lower image. You can pick both images. Now, I just for benefit to show you, I took the upper one out, and you can see the virtual teeth in position on the lower teeth. So I know those are correctly positioned. And then you see on the left side, you see the rectangles are showing me the plan. The first line outside the blue, this line over here, I can see, you see when my cursor, that's a millimeter, that's 2 millimeters. So you can see where I am in the distance between the implants is going to be 3. So we're in good shape. And then we put the implants in, but you can see I can take the lower teeth out. I can look at it a variety of different ways. And this is very easy for me. I find that this is an easy way for me to be able to deliver very accurate care for the patient. And then subsequently, when the implants are in, you can see they're lined straight up and down. And you can see, if you look on the left, you see the blue, you see the plan, and sure enough, on the right, you see it's pretty close. And so this is within a pretty good jumping distance of being right. You notice on the right side here, you notice the inclination here is going against toward the working cusp of the opposite arch, which is what you want. So this is an easy way of doing this. It should work out fine for you. The other thing that I think is really important is scan bodies. So I saw a patient today, and the dentist says, "Can you do the scan body?" And I didn't know what lab he was using. So I didn't have the scan body for that particular lab. See, the scan bodies have libraries, and so the lab you're using must have that library of scan bodies. And then we can give you the scan bodies because you can really use them. So, but this patient here, I knew the scan body that I needed for this particular patient. And so I took the healing abutment, I scanned the patient with the healing abutments in place. Then I just took those out, and you just eliminate that one little area, put the scan bodies in and rescan just those. So you just rescan this area here, and then you get these images. This is the opposing arch. I then took that and emailed it to the lab. That's all I had to do. And she got her restorations made. So, and this happened to be somebody who had the lab work and work done in North Carolina, and I was in New Orleans. So it was really easy for the patient. So just to show you. So now let's just take this and take another step. 23-year-old dental student, and she has agenesis of the left lateral incisor. And we see these patients all the time. The high smile line, and when you see this picture you see on the upper left, you see the acrylic on the flipper. That always tells me there's a deficiency in the ridge, and so I would rather not see so much of that. So I may remove it or have my referrals remove it if they can. You can see she's got a concavity there. And if you look at the cone beam, and you can see, I always take it with the clip. You see this BBs here? That's in case I can put it in at the same time. Well, this is a little narrow, and I really need to augment this lateral approach here, which is what I did. So you can see, if you look at it occlusally, you can see the depression. I'm going to make an incision on the crest over here and then go around the necks of the teeth. And I'll elevate that tissue up all the way up to the piriform rim. And then on this case, I use a sonic weld. It's a foil made of sugars. And we used to use resorbable plates with the material, but I've tacked it in so it's tacked with resorbable tacks. And then I've got this spanning it, and then I graft underneath it. So I've grafted all underneath it and all the way up here to the piriform rim. So I very densely have a graft in there. It's a xenograft. And then I suture the patient closed, and she heals. And you can see the graft on the right, on your screen, to the right side of your screen is pretty reasonable. So we do that, and we come back to this patient down the road. But to make sure I get the workup done right, since I want to angle the implant for a screw retain restoration, I get the intraoral scan. See, again, I'm scanning a lot of patients. 10 minutes a scan, 8 minutes a scan, depending on who's doing it. My assistants can scan them, I can scan them, it's whoever's available. So we just scan them, and there's no powder with this particular scanner, which is nice. Just dry off the teeth and you go to town. Very simple, very simple. And then we take this image and we superimpose it on the CT scan, and then I place a fake lateral in there, a virtual tooth. Now what you're seeing here is the first lineup of an implant. Now this would tell me, if we left it like this, that this would have to be a cemented restoration because of the way it's coming out. It's very hard to do this restoration screw retain. Well, my referral was a very good prosthodontist, said I would like this screw retain. So I said, all right, well I'll just take the implant and angle it a little differently so it comes out more on the lingual aspect. Well, now it could be screw retain. But now what I have to do, you see, is follow that plan. So if I was just going to do this freehand, I might have a tough time putting this in exactly where it needs to go. And then he says he wants me to distalize the height of contour of the implant 1/2 millimeter. 1/2 millimeter. So I used to look at people who told me that and say, sure, but I never did it. But now I can do this with, believe it or not, you can be a 0.5 millimeter accurate on these. So here we are at surgery, and we're going to do the surgery. We calibrate the machine. We make sure the clip is right. So I'm making sure everything is lined up on the drill. And if you can see that the middle dot there is 0, the first click on that is a millimeter. So if I just stay between the middle and the first click, I'm a 0.5 millimeter distal, which is exactly what he wanted. And so I'm drilling the holes, and I'm drilling these holes looking at the screen, and I'm being very, very careful. And I go just to the right depth, and then I use the series of drills that we need to put an implant in. And you can, this is very generic, so this is a 3.5 by 15 millimeter implant. And we're just drilling the holes. And you can see, though, I'm very, very careful because there's a sequence of drills that you use. But I'm able to place this implant exactly where he wants it, exactly. And I can do that because of the magnification and the specific, the exactness of the system. And I think this would be really hard for me to do this accurately freehand. I really think it'd be hard. So, excuse me, I like to do it this way. Now, so the implant's in place. So now you see the implant's in place. We've got good labial protection on it. And it's distalized just a little bit, just like he wanted. He was happy, happy, happy. He just thought it was great. So here she is, being just about ready to be restored. She's got a little bit of soft tissue maturation occur. He's going to change the sulcus underneath that a little bit to build it out. And so she's looking a lot better. She thinks it's pretty good. So this woman comes in. So, you know, I'm moving quite along, but I want to make sure we have enough time for questions. So this young lady, 29 years old, and she was standing on her boyfriend's shoulders, and he let go, and she face planted. And so she had a very significant injury to the anterior maxilla, a couple of abrasions, as you see there. And cute girl, high smile line. She had a perfect set of teeth. I mean, absolutely perfect. You ever see patients come in and say, "I'm going to get a picture of them because the teeth are so perfect"? Well, that's her. Now she's seen in the emergency room, and one of the oral surgery residents stabilized teeth with wire, and then she went to see a dentist 2 days later, and he put this thing in her mouth, which is wrong. It's not right. There's a lot of things wrong with it. You know, the edges aren't trimmed. I mean, it's impressing itself against the soft tissue. There's no room for the soft tissue to breathe. Remember, trauma, you have hematomas, you have avascular problems. You need some space. So I sent her over to one of my friends. But first I got a scan on her. She came to see me because I've treated some of her friends and some of her friends' family that we know of. So you can see in the scan, I mean, number 7 is subluxed, number 8 is gone. But you notice the acrylic, the resin that was put in is pressing against the bone. That's not good. Number 9 is subluxed. And number 10 is root tipped. It's still in place. So I'm, as a surgeon, I'm thinking, if I operate on this patient real quick, I'm going to probably lose more soft tissue. So just wanted to keep it kind of in place to let it heal. So another dentist took everything off. As you see here, you can see the wound. And then he went ahead and bonded a wire to it and put some fake teeth on there. So now she has a wire in there. And you can see now that everything is off the gingiva. Things are stable. You see he stabilized it back a few teeth. So she's actually quite stable like this. And she wants to know what's going to happen. So I said, we're going to let things just effervesce. We're going to see where you are. So 6 weeks after the injury, her tissues have revascularized. Obviously, there's some recession. I told her we have to do a lot of work. Then we have to know where to put the implants, but we have to graft you first. So we grafted her, and so I make an incision, raise the tissue up, and you can see the tooth and tooth roots, and it's pretty much a mess. Poor girl. And we took out the teeth, and now you can see the defects in the bone. They're pretty obvious. It's pretty hard to miss it. So what I do is I'm going to graft the intraosseous defects or allograft because that'll turn in the bone, and then I'm going to overlay some xenograft over that. And I'm also going to take a piece of soft tissue from her palate. Now, I take a subepithelial connect tissue graft from both sides of the palate because she has a long span. And I'm going to put that underneath the flap, and by doing that, when she heals, she'll have nice thick tissue. And sometimes connective tissue will actually grow vertically. So I've seen that happen quite a few times. So I'm hoping that happens with her. You can see the teeth that were taken out. They're really pretty useless teeth at this point. So here's the overlay with the xenograft. And you can see the incisions on the palate where I've taken the subepithelial connective tissue graft. And I'm going to sew that underneath the mucosal membrane here, the mucosa. Then I sew her up. So I release everything, release the periosteum, sew it up. And I thought we got a reasonable closure on this. So now she's cooking. She's just going to heal. And she heals, and that's when she heals. We get an Essex made on her, but now we're going to start, after 6 or 8 weeks, we're going to start pushing into the tissue a little bit to try to make some invaginations and try to get some tissue to grow labially, which it didn't. But now we can image her. See, now we can figure out what we have to do. So now what I did was I did the intraoral scan of her without the teeth in place, upper and lower. And so what you see on this is brought into a CT planning software called Implant. And what you'll see here is in the red on the upper left is her maxillary soft tissue and teeth. And then the green is the bone. And then on the white underneath it is, of course, her mandible and occlusion. And then the yellow teeth are virtual teeth. So I just took teeth and I put them in position. And I thought those looked pretty reasonable on it. A little bit long, but pretty close to where we need to be. And then, and you can look at it on the occlusal over here, you can see that the width is reasonable. So, and then you can see the grafts that we placed in. So, poor girl. So when you look at this a little closer and then you measure the length of the teeth, you see it's 11.99, and she's relatively petite. She's 5'2", kind of an oval face, so probably 10.5 millimeters is about the right height of her teeth. She can go to 11, but not much more than that. So we want to make some space and let the tissue come down. So I told her that most likely she may need a little pink on the gingival level, high smile line. But that 11.99 is telling me that we may have some problems with soft tissue. So we got her a real good flipper. A very good dentist made her this flipper, which now is giving her a very, very good sense of proportions of where the teeth need to go and her needs. So she's very, very happy with where she is right at this moment. Still devastated by the injury, but not bad. So now we have this flipper. I imaged this on her in her mouth. And by doing that, I now have an image of where the teeth need to go, because now I have the right setup. See, you have to have the right setup. Now, I could have done this with a stent without any of the red on it, but I just ignored the red when I did the implant setup. So now I'm bringing those images into play. Now, this is what I like to do. I have the green is the bone. The kind of reddish orange is her soft tissue and the flipper. But what I want to do is I want to see where those teeth are related to the bone. So I put virtual teeth over and within the planned setup. So those are virtual teeth, and I try to superimpose them just right so it's pretty much exactly where those other teeth are. There might be a little bit out here and there, but not much. It's pretty close. So now with one click, I can take off the red and see where the virtual teeth are related to the bone. And that tells me about implants. Now on her, 2 implants is our plan, and we want to screw retain this. So we don't have enough space to do 4 implants on her. There's just not enough space. But now what you can do is you can take on the upper left here and over here, you can see I've taken off the red, which is the model, and you can see where we are for the implants in the bone. And we're pretty close. I mean, that's maybe 3 millimeters, so we're not too bad on the laterals. A little more space here, not too bad here, not too bad actually. And you can see where the implant's going to be coming out. So now what we do is we take that image and we look at it a little closer. We look at the implant positioning. So now we know the size of the implants, we know the angle, and we know where we're going to go, all because we have a really good setup, and we've digitally transferred that setup to this planning software. It's very simple to do. And this is the simplest way. You don't have to worry about barium sulfate. You don't have to worry about anything else. It just goes right on, and you can click it on and off. So then we get a guide stent made, a static guide, and you can see the implants are timed. So the internal flat will be up to the labial, and we put them in. This is her at the time of surgery. So we use this to place the implants. And what I did is I made an incision before I did that, as you see here, and I just pushed that tissue out. So rather than remove a circle of tissue, I moved it out to the labial. And by doing that, it really helps it. I mean, all of a sudden, we're really doing well as far as being able to bulk that tissue up, because my goal is to get rid of the pink. I have no pink on it. And we're getting pretty close. So you can see the images here, very precision placed. It's very important to precisely place the implants exactly where they need to go. The only way I knew where to go was the digital imaging of the setup, which was easy. I mean, that's a no-brainer. And I don't have to spend a lot of time on it. It's very efficient. Now, when you see her healing after 4 months, look at the ridge and the curvature. You're starting to see this is starting to look much better now. Remember what she started with. So at this point, we've got something we can work with. So now I tested and sent her up to my buddy, and he went ahead and made her a screw retain temporary. Basically took the flipper and changed it out. Now, when I see this, the first thing I think is, there's a millimeter of red on the gingiva there. Why do you need that? Why don't you take that off, leave the space, and let the gingiva come down, which is what he's in the process of doing now. So, but this is pretty close. I mean, she's getting pretty close to being made a final. I just want to see I want to see how she looks without that red on there. She may wear this temporary for 6 months, but that's okay. All the soft tissue underneath that flap will grow just a little bit, but I only need a millimeter, and then we got it going. So, something to say. Now, look at this patient. So this patient comes in, and I'm showing you, I want to show you a patient that we really find the imaging makes a major difference. So this woman comes in and she smiles and she says, see? And I went, I see. So she had implants placed for the laterals, 7 and 10, by somebody 10 years ago who just put them in. And then she had the abutments made and the crowns. And when she smiles, she's a young lady and she's got a high smile on, and it's kind of ugly. She's got some spacing issues too, which I'm going to get into. And you notice that the canines are not symmetric. One is turned in on the right, her right, then your left, and on your right, her left. You see it's turned out. That's more of a male tooth, so we don't want that. But you see there's some asymmetry in the arch. So when you look at her carefully, you can see a couple of things. First is that the soft tissue is really thin over the implant. It's almost dark and gray. Not stippled, it's not pink. This is a case where if you don't pay attention to soft tissue, you're going to have recession, and it's going to look worse before it looks better. And you notice the asymmetry of the centrals and the midline zone. Besides that, she's perfect. All right, so we look at the skin. You see, obviously, these implants are too superficial. They're not deep enough, and they're too far labial, especially the one on our right screen. This one over here. So I don't know how to save that otherwise. So we take everything off over the abutment, put cover screws on, let her just sit. So about 8 weeks later, we come back, and now she's ready to have surgery. This is a nice way of doing it. You jump in right away, you're not going to notice soft tissue. So let the soft tissue heal up and close the wound. And then I'm going to elevate a flap on this case. And this is the only time we really elevate a flap on her. So when I elevate the flap, you can see the implant in position. You see how thin the bone is. You see the histons up here. Same thing on the other side. So we took them out. I use a piezo surgery unit, the real one, and I go in between the teeth, and then between the implants and the bone, and then I sublux it and rotate them out. So now I have this defect up here in the canine area, and then I have the defects here, so, and thin tissue. So I put allograft in here, which is what I do, and this piece of collagen, but the big thing is connective tissue from the palate. I'll take that connective tissue and put it on top of that collagen membrane, and really kind of thicken the tissue up. So we'll get thickened tissue both from the collagen and from the subepithelial connective tissue there. Not a sew up, but you got to handle the soft tissue. When you see thin tissue, convert it from thin to thick. Now I got our graft in position. It looks pretty good. That's the immediate post-op. So I think we've achieved the beginning part of a reconstruction. Now what you see here on the left is before, and on the right is after the graft. You can see that the tissue now is much more stippled, pink, thick. You're seeing I got a much prettier architecture to it. Now from this, we should be able to do anything we want, and because it's thick, we won't have recession. So that's what we do. So the first thing, the Essex is made. That's her temporary. She needs to learn how to brush it better, but she's doing all right. But then the dentist, having a prosthodontist, put some material in, some resin, to start pushing into the tissues here to make the sulcus. But you don't put anything in the papillae. You have to make sure the papillae are cleared. Put it right up here. And by doing that, and this is just on the Essex, just add a little resin to it. Add a little resin, polish it down, and you can see it's more triangular shape here, just like you would see the root evidence of the tooth. And then you put it in. And then when you do that over a period of time, which is going to take about 6 to 8 weeks, all of a sudden you got sulcus there. Now you can start thinking, oh, this is well shaped. And you can start planning. Now, so I image that. I take my intraoral scanner, my Carestream 3600, and I scan the patient. Do it all the time. And I take that and I put it into my CT planning software, whichever one you want, but it works for both. But you can stitch any of these STL images into them. Now I got an occlusion. And so what I do is I take it and I look at it. I can rotate the whole thing. I can look at it from underneath. I like the horizontal projection we're getting. So now I put virtual teeth in. I just choose some laterals, put it in there, shape them, size them, 6 millimeters, 6.5, whatever it is. Put them in position. And you can see that there's going to be some diastomers for the central. Central is actually too narrow. So what do I do then? Well, I take this image and you can see on the right side the smudging from the CT scan, which is why I have the setup in there. And so now I'm ready to go. So I take what she has now, and I'm saying I'm going to make this even prettier. I put some virtual centrals in there. So I take some central incisors, virtual teeth, I put them right in position, size them, shape them so that they're proportional. And then, once you get that in position, you start saying, aha, this is why we need to treat her. So now what we need to do, we have very, very easily, we've taken her totally digitally into the plan, and we've played with the spacing, with the proportions of the teeth, and this is really simple to do. It's not hard to do. You just sit there and play. It's like a video game, and you can play it, and you really, I mean, I have so much fun doing this, I don't even want to charge the patient for doing this. I'll charge them for some things, but not this. Anyway, so now we have it all set. So now we have, I put everything in, and I called my referral, and I said, look, I got it all done, Raj. And he says, oh, I don't believe you. He said, yeah, that's good. He said, I want to challenge the system. So what he does, he didn't believe that the digital would work. So he got a setup done by his lab tech. It was very good. Beautiful setup without really looking at what I did. And so then I took the setup and I scanned it with the scanner. So now I have a scan of his setup, his model. And then I stitched that on top of the CT scan, and then I put the implants in according to that setup. So now you see them, and you know what? I could superimpose these images. They're exactly the same. And that's what we decided. He was amazed. He loved it. So then we went ahead and put the implants in, as you see here. I got some impressions on it. You can see we have a 7 and 10 straight up and down. So we got them lined up. They're coming out on the lingual, so this is going to be screw retained. Now, the other thing we want to do is do an immediate restoration. So we're going to take here's the plan. You just press a couple buttons and you get through CT guide. And then you upload it and send them a model of the patient so they can get the occlusal surface squared away. Or you can upload an intraoral scanner if you want. So I did it this way. Now we get the stent back, we got the sleeves for the static guide, and you can put parts in there, and the parts will allow you to then have a model that you can make a temporary, which is what we did. So here are the implants in position on her, and you notice that I have it timed. Here's the labia, and you notice it's all timed so that the flats are going out to the labial, which is important. And then the temporaries get put in. There's a little height difference because somebody didn't use the right parts or something like that. So it goes in, and then my referral was there, and he just took his high speed and he just lopped it off and squared it up so that it was in the right position. So you can see him, a little action shot there, trimming the provisional. And here it is, screwed in place, and they're about where they want to be. They're right in the right spot. And then because they're back a little bit and because they're deep enough, she works. She looks great. I mean, she doesn't show any of the metal like she did before. Now, of course, these are lighter than her other teeth. Other teeth need to be cleaned up a little bit, but you can see it's screw retained, and this is key. And the reason I was able to do this was because of the imaging that we did, the planning that we did, and then of course the rest of it. So she's going right along. She's getting her final restorations done right now, which should be quite attractive for her. Now the other thing you can do is figure out some trauma cases or some other cases. This young man was in a bicycle accident, and he completely avulsed his central incisors and the bone, and not the soft tissues. Relatively clean extractions except for the bone. And so you can see on the left, both 8 and 9, you can see on the left that the screen here shows you the lack of bone that he had. And then we grafted it, so we got a lot of bone back, and then we have the implant in position. Now, the reason I looked at this, I was saying, I'm not sure about this. So I scanned him intraorally and superimposed the scan and put teeth that were going to be proportional to what he needed. These are 11 millimeter tall teeth. And you can see obviously you can see the lack of the papillae in between. And I told him, I said, unless I do a bunch of surgery on you to bring that bone back down, you're going to be stuck with that. He says, I'm fine. And the dentist is going to put some pink material in it. But we knew that before the implants went in, which is what I wanted to show you. And this really is important because patient sees the expectation. And then when he doesn't have papillae, he's okay with it. It's all right for him. And now this woman here, I just got a couple of cases, and then we'll take some questions. This woman here comes in. She has aniridia, which is loss of iris tissue. But she has some dental problem along with it. It kind of follows it. And what we did is we grafted her with a tunnel on the alveolus, and then we came back and did implants. But the only way you know where to put implants in this kind of patient is do a setup. And you really have to do a setup. So her restorative dentist went ahead and got models and did a setup and got teeth set up just so that it would be in occlusion and look good on her. So this was tried in her mouth, and when it was tried in her mouth, she liked it and she thought it was great. So now what I need to do is use this to plan the implant placement. So I take this model, I scan it with the Carestream. So I scan it and superimpose it on the CT scan, and now I can put implants in all day long. But I know exactly where they have to come out. Not only do I know where they have to come out, but I can choose angled abutments. So when I first started doing it, everything was up and down, but they really weren't ideally placed because they were too far anterior. So we went ahead and we angled them so we have more freedom from the end. We didn't want the centrals to be involved. And I have to reduce bone. So I was able to reduce the bone on the CT scan, on the planning software, put the implants in. But see the angles? Well, we actually used the CT planning software with everything else to plan which angled multi-unit abutments to place on her. So we knew exactly what implants to place. And so we did that, and now here are the abutments. The regulars, there's 5 millimeter tall abutments. We did quite a large Veloplast. Here she is in temps. Now the canine site is a little bit high, but she doesn't show any of that when she smiles. So she's actually quite thrilled with this. And once it shows that she can maintain the hygiene and there's no other problems, then it'll be made into a zirconia prosthesis. But the planning, again, the only reason I know where to put the implants and how high they had to be was the plan. So I took the plan, and then I went higher than that to make sure I knew where the height of the platforms needed to be. And I wouldn't know any of that unless I did this. Otherwise, you'd be more superficial, which would be bad. So let me finish up on this case because we're almost at 45 minutes. This is a 65-year-old female who said, at the end of this treatment, I just want to smile. I just want to smile. That's all I want to do is smile. And she did have some issues. She had missing some teeth. She had the diastema. A wonderful, attractive woman just doesn't want to smile, and you can't blame her. Now, the problem with a lot of these teeth, a lot of these patients who are in mixed dentition, is the teeth have shifted. So if you use the tooth sites to guide your implant placement, they're not going to work. They're just not going to work at all. So this is the kind of case where we take the regular dentistry we've learned all over the years, and we look at her and we say, you know what, we need to do some work on the bottom, true. But on the top, we need a good setup. We need to know where the teeth need to go. So models were made, they were mounted in articulators, sent to a good lab. But before I did that, they had me take a scan. And when I'm looking at the scan, I'm looking at the bone from canine back on both sides, canine back on both sides. I'm plenty of bone. So if I leave all the incisors alone, then they can ridge lap those all day long. They can do whatever they want. Canine back, very easy to clean. So that's what we're going to do. So now here's the setup. You see on the left the way it was originally, and then on the right the wax up. So most labs will tell you that even though you can do a lot of things digitally, a really good wax up gives you the art of the tooth. You know, the height of contour, mean distalized, all these things, which is what we did. And then the lab converted that as they normally would. They optically scanned it and milled out a provisional. This is a one-piece PMMA provisional. And notice there's no paint on it, just teeth. Because when you just take out teeth, you're just missing teeth, no gum. You don't need to replace the gum. So just make it crown and bridge. And then this is our little guide here to be able to seat it on the palate. And you can see it's hollowed out, and then resin will fill that up to create strength. And it's easy. So I took the plan, the models that they made of the setup, the lab imaged them, sent me, I could have done it with my scanner, but they didn't. So then they sent me the STL image. I superimposed that on the CAT scan, on the cone beam, and then I put implants in. As you see up here, you see how this one here, this implant is not on the canine. It's actually a premolar. It's moved forward. So those are the kind of things you can see, and now you can line them right up where they have to come out. And you can see I have them lined up right where they're supposed to come out on both sides. So this gives the planning, and the only way to plan, I knew where to put the implants was based on the plan. That's the only way I knew what to do. And then you can see on the posterior right, I had to angle it a little bit to get it in place, which is fine. Using angled abutment. So here we did the surgery. So I put the patient tracking array in the front, and then I did this side, and then I took it out and reversed it, did this side. So everything was navigated, and then I put the implants in. Now once the implants are in, navigated, then I treat these like single tooth sites. I just treat it like extraction sites. It's really easy. So then I get to this point, and then she goes down the hall, and the dentist, who was very good, went ahead and just converted it, picked them up, and trimmed them down, and then screwed them in. So it was pretty quick. We had a bite, we had a registry, so we knew where to go. And here she is after. Now the best thing about this is that we did the surgery, but you want to leave space between the gingiva. Leave the space. Don't put pink on it at this point. It's right after surgery. Let the gingiva come down, and it will. It'll come down. 2 weeks later, look at her. She's looking great. And her lipstick is better, and the gingiva is contouring nice. This is this is going to work really well. Don't put pink on this. Don't put any pink. Do everything without pink, and make the teeth the right height. 10.5 millimeters height on the centrals for her. And then this is her final prosthesis made of zirconia. It's screw retained. It's one piece, and it just looks great. And when she wears it, this is her. This is her upper lip, so you can see how much she shows. And he probably could have removed this papillion here if he wanted to. But she just loves it. She just loves it, loves it, loves it. You go from the left to the right, and she's just happy, happy. And you can make the teeth more characterized if you want, or you can make them whatever you want. Look at her smile. I say, "We don't give me a smile," and she couldn't stop smiling. She couldn't stop smiling. So this is the sort of thing I wanted to show you, is how you can use all the digital imaging for this work. So I'm going to stop there, and then we can take some questions and do what you need to do. So I just want to appreciate the opportunity. So do we have any questions?
Yeah, thank you, Dr. Block. Before we do our questions, I'd like to invite viewers to use the question box in the control panel to ask any questions that you may have. And we will ask Dr. Block.
Dr. Block, please turn your volume up on your computer.
I don't hear you.
Okay, can you hear me now? As they say on TV?
So how are we doing? I got a message from somebody. Let's see. Turn the volume up on the computer. I thought I did. Can you hear me?
I can hear you. Can you hear me, Dr. Block?
I can hear you now, yes.
Okay, great. Well, I was saying that before I get to questions from the audience, we're going to invite the viewers to use the question box in their control panel to ask any questions that they may have. And one question that I have is, how do digital impressions save you time in your practice? How much time do they save?
Well, for me, they save a lot of time, because I don't have to send the patient to my referral for impressions and a workup and all set up. So it saves all of that time. I can literally take the digital scan in 7 minutes. My assistants can do it. And I just put it right on the CT scan. So I don't have to worry about making a barium sulfate stent and then interpreting it and trimming it. I don't do all that. It's almost like no time at all. It's so simple. It saves a tremendous amount of time for the whole team. So that's what I find.
And how does the digital workflow make implant planning easier?
Well, the digital workflow makes it easier for me to know where to put the implants, because I get the STL image and I superimpose that onto the CT scan. And then when I do that, I can very easily put the virtual teeth and I'm ready to go. So it makes it very fluid. There's no missing steps. I don't have to rely on a lab doing something. I don't have to rely on my referrals seeing the patient. The patient does not have to go to 3 different offices to get something done. We can do everything right there, which is really good for the patient.
Do you find digital impressions to be more accurate?
I find digital impressions to be accurate. The literature says they're as accurate as a well-made impression. Some impressions are better than others. Some imaging, if you don't image the case right, you're not going to have an accurate impression. So you have to image it right. But it's very accurate. More accurate than a good impression. I'm not the right person to answer that, but I hear that it's as accurate. There are some accuracies here that are good because there's no printing. If I print a model with an inexpensive printer, it won't be very accurate. And then when you digitally image around a whole arch, that's where you start getting more error. So if you digitally print, if I'm going to do an implant impression, and I do a small segment, very accurate. If I'm trying to image the entire set of implants on a full arch, not as accurate. And that's well shown.
Okay, do you find the experience better for the patient? Can you tell us a little bit about what patients how they have reacted?
Well, patients love the technology. They think it's cool. So it doesn't hurt them. They don't have all the goop in their mouth, so they like that. They get to see how we use the technology on the cone beams to plan their case. So I show it to them. They love it. They think they're in a very technologically up-to-date, state-of-the-art facility, which is what we like. And the other thing for the patient is they just find the actual scanning easy. When I'm not shooting powder in their mouth or anything like that. I'm just I'm kind of like humming when I'm working, and they kind of enjoy it. They're watching the image on the screen too. I have them sitting up so they can watch my scan when I'm scanning them right on the screen. They love the technology. They think it's great.
So that digital impressions, you would say, helps with patient education, and does that translate to referrals, since they understand what's happening to them?
Well, the patients like the idea that their dentist is referring the patient to me because I'm using technology, and the dentists like it because the accuracy is so good. They don't have to worry about a lab doing something. They don't have to pay the lab to do the setup. It's very effective for the referrals. Overall, the whole team, it just works better. Now you have to communicate with everybody. You have to send the images to the referral, say, do you like this? Some come over to my office and we tweak it a little bit. And that's all good. The more communication you have between the team members, the better the patient has. So it's good for the patient.
And leading to that question of the advantages of digital technology in your office, what are the advantages of digital technology to help with communication with your colleagues, and how does that work?
Well, we all know that if you have a well-made plan, then if you follow that plan, you're going to have good results. So the first thing it does is it makes everyone focus on the case. And by focusing on the case, you tend to be more thorough. So the digital imaging makes me look at my cases and then transferring that information to my referral very easily. It could be electronically done with the right compliance. They can come see it, and then together we can do this work. And they haven't had to do any impressions and use stone models and send to the lab. It just makes it so efficient. But it's a plan. You see, you have to have a good plan. And sometimes we probably don't plan well enough. Sometimes we just don't spend the time we need doing it. Now, I'm not saying that anyone doesn't do it, but we need to plan better. And this makes it much easier to plan, much more time effective. Because our time is very valuable. I mean, all of us are busy. We all have families. We have things to do. So it's very efficient.
Excellent. Well, we are coming up on the hour, and I wanted to thank everyone for the questions, and I want to thank Dr. Block, but we've run out of time today. So if we did not get to your question, we will answer it after the webinar via email. But I want to thank you all for attending. A special thank you to Dr. Block for a great presentation, and our sponsor for this webinar, Carestream Dental. Thank you, and have a great evening.
Thank you.